Your body is more like an ecosystem. It's not a broken down car. You buy it once, it depreciates over time, and we break down, right?
Right.
It's always working to repair. It's a wear and repair process going on, not a wear and tear.
If you've ever dealt with chronic pain, you know it's not just about what's going on in your body because it affects your whole life. And sometimes, even if you've had test after test, you're still left without the real answer of what's going on or any relief from the pain. In today's episode, I am talking with Emily Warren. She is a doctor of physical therapy and owner of Mindful Movement Physical Therapy here in Holiday, Utah. Her clinic specializes in spine care, pelvic health, but also chronic pain, and they take a really wonderful whole person approach to healing. Emily is here with us today, and she is going to share her approach to healing and help us break down the different types of pain from injury, pain from inflammation, pain that comes from having a sensitive or overwhelmed nervous system, which a lot of us don't know about. We talk about how emotions and stress and past experiences, even our daily habits, can all play a role in what we're feeling, and most importantly, what we can do about it. So if you've ever been told that your pain is just in your head, or you're told that there's nothing wrong with you, you're just having pain, then please listen to this and share it with someone who you know is having chronic pain because it is super helpful. I'm so excited for you to listen.
So if we get a client who just really feels like they have no power in anything, they can't do anything about their pain, probably because they've been seeing so many people. Yeah. Research has shown they do not need passive treatments. The thing that actually can help is them feeling successful in their body.
Emily, thanks for coming today. I think this is such an important conversation that we're going to have today about pain. So thank you for coming and sharing your wisdom and your expertise.
Thank you for having me. I'm really excited to be here and hope this will be helpful for a lot of people, or insightful at least.
Sure, of course. Now, as a physical therapist, you deal with pain, right? Usually people are coming to you because of pain, maybe occasionally because something else is happening, but by and large, most people are coming to you because they're hurting. Tell us just briefly, how did you get into physical therapy? And then how especially have you become so passionate about helping people with their pain?
I've been a PT for 13 years. And before that, I had a background in psychology. So I've always been interested in the human experience of pain. I started in inpatient, more like rehab, working with spinal cord injury, brain injury, stroke. Neuro was my first love as a physical therapist. And I saw, every person I treated was in a good amount of pain. And I really grew to appreciate the brain as the powerhouse for movement and also pain. And then in my transition out of neuro rehab, I transitioned more into orthopedics. And it's similar problems, right? We're working with people in pain, and I won't even say a lot of pain or a little pain. People are in pain, right? And have pain and movement problems. And I just became more convinced, like I need to get better at helping the person in pain rather than but it's important, like strengthening muscles. And so over the process of being a PT for 13 years, I've just become an avid learner. Like I need to get better because chronic pain is a huge problem and I want to help people. And so that's been a bit of my process as a PT. I'm now in orthopedics. I specialize in the spine and pelvic health and see a lot of joint pain. Back pain is probably the biggest. Back pain, hip pain, neck pain, osteoporosis-related injuries like a fracture, and then the pain resulting from that. So that's a bit of a picture of where I've come from and my background. Always been interested in pain and how I can help people.
Well, I'm so glad, that you do what you do. I think in medicine, it's really easy for us when we deal with the same thing over and over to kind of just put a label on it and say, like, you've got back pain, you've got hip pain, you've got whatever. But from the patient experience, it has such huge effects on their lives. Even
Absolutely.
just mild chronic pain can really start to make you feel a little crazy sometimes because you just can't keep having that. So people with chronic headaches or chronic neck pain where it's just constantly nagging, it doesn't have to be totally debilitating pain to be quite limiting or to have an effect on your life. So I love that you take it so seriously. I see a lot of patients who I recommend go to physical therapy or have come to me after physical therapy. And one of the complaints that they often get is like, yeah, it didn't really do anything, right? Like I went to physical therapy, they gave me some exercises, nothing really helped. And I do think part of that is because people don't always do their exercises, right? As a patient, I know that's true. But I also think that a big part of that is because oftentimes the person treating their pain doesn't see pain with the big picture that it is, right? They're just looking at, you have some pain in your knee. I also notice that when I do an assessment, you're weak over here. Therefore, be strong over there, and then your pain will go away. And it's really so much more complicated than that. So we're going to really take a more comprehensive look at pain today so that people can see opportunities to get rid of pain, which is really, we care about function and we care about the experience.
Yeah.
So let's start with the very absolute basics. Can you just define what pain is?
Yeah, so pain, the official definition is it's an unpleasant sensory and emotional experience with or without tissue damage.
Okay.
And so just breaking that down a little bit more, it's sensory and emotional. Sensory is just physical, right? It doesn't say or emotional. So it's just both.
Yeah.
Okay. And then with that statement, I sometimes explain to my patients, it's like your brain is in a tiny black box, and that black box is your skull. And this is a metaphor by Lisa Feldman Barrett. I love how she explains it. Your brain works out of prediction to keep you alive and safe. And so your brain is getting all this data from your internal environment and from your external environment. It's in a black box. It doesn't know that this is a psychological interaction. It doesn't make a difference between the physiological data from your body and then your interactions with your people and your environment and your food, all of the things. It's just making data. It's taking in data and it's making an output of pain. Yeah. And so that's why I like to break down. I can't separate the two. Like I'm very interested in a person in pain. What's the context around their pain? Because it matters. And then to break down the other part of like, it can be related with tissue damage or tissue injury, and you can have pain without tissue damage or injury.
I just want to highlight that because I think we forget about that.
Totally.
Right?
Even practitioners, like we do, right?
Right.
As a PT, coming out of PT school, no one told me that.
Yeah.
I'm just thinking, oh, what's the structure problem? Let's fix the structure.
Yeah.
But pain is just a bigger experience. You can have pain. You can have tissue damage. You can have tissue damage, no pain. Plenty of us are walking around with degenerative changes in our spine, degenerative changes in our knee, disc bulges, even herniations in 20 and 30-year-olds. They've done studies and images of people, and they're not symptomatic. And so that's when we have to start to separate the two and say, hey, there's something bigger going on here. Your body is more like an ecosystem. It's not a broken down car. You buy it once, it depreciates over time, and we break down, right?
Right.
Your body's an ecosystem. It's always working to repair. It's a wear and repair process going on, not a wear and tear. And I think the language we use in medicine needs to change with people with pain, right? And I tend to take a more optimistic approach on that. So that's a lot right there.
Yeah,
right?
and I want to reiterate a couple of those things because I do think it's super important. Number one, if there's tissue injury or tissue damage, right? You sprained your ankle, you broke a bone, you tore a ligament, you dislocated something, that's a legitimate pain response, right? And there's the physical, we'll get into this in a minute, but there's the physical nerves that say, ouch. Like that tore, ouch. Your brain says, I can feel that caused me pain. But at the same time, your body is taking in the rest of it. The brain takes in the rest of the circumstances around it and also kind of says, file save, right?
Yeah,
like
absolutely.
It says, I'm going to remember that. I'm going to remember this whole context. So if it was a one-time injury or if it was a traumatic injury that was associated with other horrendous emotional impact, or if it's over and over and over, then you still have that nerve sending the signal saying, ouch. But then you have the emotional part of the brain saying, I remember what happened here. And saying, file save, override, right? Like it's just,
I'm going to
as
protect
you said,
I'm going to protect
exactly, taking in that data. And one of the things that is so important in this is when people have, especially chronic pain, so we'll break it down a little bit more for acute pain and chronic pain, but especially when someone has chronic pain, it's really easy for us because we're, as patients, we're used to the conventional medical paradigm, which is you have a problem, let's keep imaging until we find the tissue damage. And that seems like a really good idea, right? So we have chronic pain and we're like, let's look again. Let's get a different MRI. Let's try this. Let's try this. And I think that's good. It's definitely good to understand. But just because there is tissue damage around the area that you're having pain does not mean that the tissue damage is responsible for the pain.
Absolutely.
And that seems very counterintuitive to people.
I know.
But it can lead to ongoing pain because you keep managing this tissue damage that is not the source of the pain. Or even worse, you end up with surgeries and interventions that can make things worse. And the idea that, like what you mentioned of people having degenerative disc disease, walking around perfectly fine is so important for people to know. Because the fact is, if we image you enough, we will find evidence of wear and tear on your body.
It's going fishing for
right.
something.
Yeah, keep looking. You'll find something. But then you feel obligated to fix it, which could make things worse.
Yeah.
So I guess I didn't really need to reiterate that, but I just think it's important to really understand this idea of different types of pain. And also, just because you find tissue damage doesn't necessarily mean that's your answer.
Right.
Right.
It's a part of the story,
Yes.
right? Like, so if you think of pain as like a cup that overflows, the overflowing is the pain. Okay. And there's different things that fill up that cup that make the pain overflow. And one of those is structure. So it's important to me. I do want to know what's on someone's image if they bring to me an x-ray or image. A lot of times I like to see it after I evaluate them.
Yeah.
So I can have an unbiased approach there. Anyway, structure, genetics, sleep, worry, these things fill the cup. And there's been research around it. We're learning more. And then the cup overflows for whatever reason. Okay. And so structure is a part of that, and it's important. And we can get that structure if we create the optimal environment for healing. We can get it to calm down. But there's so many opportunities to help people worry, stress, inflammation, right? And we deal with like perimenopause, all of that.
Hormones,
Hormones are huge. So there's so many ways to go at it. And I just want a structure and image is one thing, but we can work on either building the cup, like getting a bigger cup, getting more resilient too, through the movement and our choices. We can also work on the other stuff to decrease the sensitivity of someone and their pain experience. And so I think people just need to know that, right? Structure and tissue matter for sure.
Yeah, I love the way that you're describing that. I want to make sure that we're understanding you correctly. So are you saying that if someone is experiencing a lot of stress in their life or, has other aspects of their life that are not necessarily related to the injury, that can actually change their perception of the pain they're going through? We have data on that. Is that what you're saying?
Yes.
Yeah.
It can increase their sensitivity to pain. Because remember the black box analogy, your brain doesn't know. We make the distinction between emotional and physical, right? It's getting in this data and it's making a physiological response in your body. Yeah. And so stress matters. And so if someone comes in to work with me and they say, I've had this pain for 2 years, I had an image, I had a disc herniation at that time, and I'm still in pain, and I want to know more, right? And it may not have been an injury that brought it on. It just came on. And I'm like, tell me the context of what was going on in your life at that time. Not because I'm like going to say, you're stressed, you need to calm down, right? It's more of like, this is the ecosystem we are dealing with. Your body is an ecosystem, and I want to understand this ecosystem and the status it's in or was in at that time your pain started, and helping them make sense of their pain experience. Because a lot of people are confused and scared. And a part of our job as practitioners, when we have that element, is like decreasing the threat value in their pain. If we kind of had an idea, like if I don't know what's going on, I'm going to refer out. But if I have a pretty good idea, part of my responsibility as a PT is helping them like to decrease the threat value, not to say you're out of alignment, your spine, the jelly donut, the discs bulged and it's splattered. I don't know. There's so many fear-mongering things that I'm just like, no. I want to learn more. And I think a lot of it's about the language we use with people in pain.
Yeah, because if you blame it only on tissue damage and we're not very good at fixing that tissue damage, then you're kind of up a creek, right? Mm-hmm. And that's pretty hopeless. Like that's not the reality of it. So many people can feel better. We're going to go into the detail of perception of pain, and you mentioned sensitivity and this threat value. I want to dive into that a little more. But before we do that, help us just be really clear on this and understand what is the difference between changing our perception of pain versus saying it's all in your head, or saying you're a hypochondriac, or saying like you're just overreacting. You don't actually have an injury. There's not real pain there. Like chill out, right? Because there's a little bit of nuance there. And I think a lot of patients have experienced the latter, where they go to seek help and they're told like, no, there's nothing wrong with you. And the patient's left saying, but I still am experiencing pain. So what are they supposed to do with that? But think like, well, I guess I'm crazy, or they're missing something, so I need to get more imaging, or I need to do more fancy stuff.
Yeah.
Like how is the idea of perception of pain different than making pain up?
Good question. Well, just talking hormonally, right? I think hormonally, our perception of pain with the drop of estrogen, I think there's been some studies, and I'm learning more in this, is how our perception of pain increases. So usually I go back to the basics on that. Like, I do think it's not helpful for practitioners. If we really don't know what's going on with a person, could we just be honest and not say, well, it's because you're stressed out.
Right.
We could say, you know what, this is, I'm not finding anything structurally. What does this mean? What do you think about it? Mm-hmm. Like, ask them. Yeah. Right? And listen better. Yeah. And then say, like, give them options. Like, what are some things we could do here? Or maybe let's have a conversation around the pain system a bit. Yeah. Keep it simple for people. People are overwhelmed anyway, right? And so there's an element where I believe every person that comes in and they are in pain. Right. But I'm not going to only pin structure on their pain. And I think that's where we get into trouble, right? We're trying to pin structure because it's less work. Well, not because it's less work for us. We're just good at that.
We just like black and white answers.
Yeah. And people are not black and white.
Right.
So I don't know if that directly answered your question.
I think that's the point. I mean, that is the point that I think is important to recognize, is that we as practitioners should believe that people are in pain, whether we know the etiology or not.
Oh, yeah.
And that's really the first step. And I think when you say, this idea of stress worsening the perception of pain, I 1000% agree with that. Our perception and stress is so key to the way that our body processes everything. Mm-hmm. But just because we say the perception of stress can worsen your pain experience does not mean we're saying you're stressed and therefore the pain is your fault and you should chill out and it's all made up. And if you just weren't so anxious, you wouldn't be having pain. Yeah. Like, those are two very different things. Mm-hmm. I don't want to tell someone that they're making something up or that they should just chill out. But at the same time, if there are ways that we can help them, then we need to, with sensitivity, say, let's look for the tissue damage. And if we don't find it, I have other options for you. We have other ways and understandings to help.
Yep.
Hey, it's Mallory. Can you do us a big favor? If you're loving the Uplift for Her podcast, we would be so grateful if you could leave us a rating or review on Apple Podcasts, Spotify, or wherever you listen. It only takes a second, but it helps us reach even more women who may need to hear our message. Click that 5-star button and let us know what you love about the podcast. Your support means the world to us. Now back to the show. When we think about different types of pain, we've kind of danced around this a little bit. Mm-hmm. Help us understand, what are these different pathways of pain? Because most of us just know, like, that hurt, therefore pain. So help us understand the different ways that the body experiences pain.
Yeah. So I like to keep it simple for myself too, so I'll kind of simplify it. So we have pain, and there's different types, and I'm looking at for this as a physical therapist, right? So we have nociceptive pain and neuropathic pain, and then nociplastic pain.
Okay.
I will simplify that. So nociceptive pain is like tissue issues, joints, muscles, tendons. There's sensory endings in our body that pick up data from that. And that data is chemical, it's pressure, mechanical load, and temperature. And then those sensors are sent to our body. Brain makes the output of pain, right? So if there's danger going on in our body can pick it up and then send it to our brain, and our brain makes that judgment. So that's nociceptive pain. Joints, we can just say nociceptive pain behaves more consistent under load and predictable. Mechanical load makes it worse. In some ways, sitting makes it worse. Standing makes it worse. Walking brings leg pain. There's all these little things we can put together. It's usually in one spot. Like, it doesn't really spread widespread pain. Okay. And it usually responds to cold, or it doesn't respond to heat as much. So this is more when we're talking about like tissue issues.
And this is what we think of, most of us are thinking of as classic pain, right? I touched the burner and I drew my hand back because my skin hurt, or I tweaked my knee and now my knee is aching and sore. Even I think you'd put in that category like gas pain, right? If you get dilation of the intestine, that doesn't have nerves like touch nerves. If you touch your intestine, you don't feel anything, but it has, you mentioned pressure receptors or stress or stretch receptors, where if you get distension in the bowel, you'll get pain, even though you're not touching that spot.
Absolutely.
So that's what we're thinking of with, most of us think of as classic pain. Okay.
Yep. And that's where we kind of get stuck in healthcare. We're looking for nociceptive pain all day long.
This nociceptive pain doesn't tend to wander, right? So you're not getting pain in this joint and then pain in my shoulder and then pain in my side. It's every time you do something, you get the pain, the same every time you have the same stimulus, you get the same outcome.
Yeah, it's pretty predictable. For the most part. It can be a little, gray here and there, but it's predictable. And then there's neuropathic. And that's where the neural tissues are irritated. And there's not chronic, but there's irritation of the neural tissue. So it usually behaves in a path down a nerve route or a nerve pathway. And those behave a little differently. They're really tough to manage. They can be tough to manage. And so there's neuropathic, and then there's also nociplastic pain. And nociplastic pain is more like central pain mechanisms. We can just say that, like your brain and spinal cord have become hypersensitive, okay? We've gotten really good with pain at this point. Usually the pain can be more widespread, multi-joint. Typically they like heat. These are just little hints, right? And then they don't respond as predictably under load. It could be like, oh, I woke up today and I feel awful and it's everywhere. And then tomorrow I'm better and it's gone, and then it'll come back, So there's just these little hints of more nociplastic or central pain mechanisms kicking the pain system up.
And is there a difference in character of the pain? So sharp or stabbing or burning or zinging or anything like that?
So neuropathic will be a bit more like sharp and electric type sensations. They come, they go. And it's a little more abrasive. I don't know what else. But honestly, with nociplastic, as I've worked with more people in pain, it's kind of can be any of it from my personal experience, but I would have to check research. Some women I've worked with have diffuse numbness and tingling down their arms, and they're told to go to a hand surgeon or something for carpal tunnel. And I'm like, hang on, let's screen the spine. We screen the spine, nothing changes. Let's work on, and this, I give them my hypothesis, and and then I have them put together their story, and it's more like, okay, let's work on the pain system through movement. Anyway. So it's a little more variable. I would say it can kind of be weird.
So, yeah, I totally agree with you. Tell us then about, if you have tissue injury, is there any sort of predictable timeline that you're like, okay, I know I had an injury. I waited my time, or I recovered, or I did whatever surgery, or is there a time that you're thinking like, that pain should have gone away by now if it was just tissue damage?
Yeah, so Great question. So tissue healing times in general, and I'm just going to keep this simple for the most part. This is like what we learn in school, and tissues heal in 12 weeks for the most part. Okay. We can just assume with a normal functioning ecosystem, that's a caveat, right? Tissues will heal within 12 weeks. Bone, muscle, tendons, ligaments, they will generally heal within 12 weeks. Now, significant disc herniations that are very irritable can take a little bit longer, 6 months. Some of the research is kind of back and forth. So tissues heal within that time frame. And then if it's lasting longer than about 12 weeks, I'm already thinking, okay, this might be a pain system problem. Time is a really big factor for me when I'm screening someone for tissue injury. And like if someone had an injury, it happened 2 weeks ago, they rolled their ankle, there was swelling, all of that, we are still in this repair process, and that guides my treatment. If this happened 2 years ago, I am less apt to say this is tissue damage every time you have pain, right? I'm not
tissue damage.
Right. I'm not thinking in my head as a PT is they are damaging something when they have pain. It's farther apart.
Yeah.
But if the time is less than 12 weeks, it's probably closer together. If you have pain and you just rolled your ankle, I'd say let's let pain be the guide in your decisions, how you load your leg. If pain is started 2 years ago, we are into pain system problems, I would say let's not use pain as our only guide here, because that's where we get stuck. Pain doesn't necessarily at that point mean that there's structural damage. It means that your pain system is on and firing, and you've gotten really good at picking up pain. And you're just, and that's just happened over time. And so what can we do? There's different approaches. So one I really like is, where are your goals and your values in life? Let's orient maybe our decisions more towards your goals and values, knowing that we are not doing damage to that structure. We are moving in a way that's like, okay, I want to move more. I want to be more healthy. I know I have pain, but I'm not going to wait for that pain to be zero to move.
I see.
So that's just how I coach people. And I do work within irritability. I'm not asking them to blow through pain and ignore it, but I'm like, let's choose a range. Like tendons, I'm like 3 or less. If it's tendon sensitivity that's lasted for a long time, I coach them on like acceptable pain, yellow light pain, let's poke into it, let's back off a bit, and then red light pain. So I want people to know what pain we think is okay to work through based on my best knowledge and learning there, and also their story, and then what they can tolerate, and then move forward through there.
So if they're having, if you feel like they're in the acute phase of injury, they've just had knee surgery and you're working with them on, rehabbing their knee, that's going to be one thing. I mean, that's a totally different approach. If it's more chronic pain now where it's going on and on and on, then the idea of it being just persistent tissue damage that you need to address the tissue damage becomes less likely. And instead, we're looking more for recovering the pain system, the brain and connection, the memory of the pain, the experience of the pain. We're working more on that and also getting function back at that point.
Yeah. So even at that point, the tissues can still be irritated, right? There can be chronic irritation. So if pain's lasting longer than 3 months, I categorize this in my brain because I need to simplify it. But I'm thinking, okay, this structure can be chronically irritated because of loading habits, right? Or other things, hormones, right? There's other things medically going on, and I use referrals for that. But chronic irritation, under load, that's fine. So we can modify that. We can work with that. We can find pain-free movement or pain minimal movement to get people moving and stronger and build self-efficacy. Chronic inflammation is one. So if the ecosystem is chronically inflamed, then it's going to be hard to get out of that. And I think that's a big one here, right? We have a lot of metabolic disease, a lot of things going on in postmenopause. So I'm screening for hormones. How are people sleeping? Sleeping is correlated with neuroinflammation. and then also nervous system sensitivity. And it can be a combo of any of these too. It's not just like I have one of those things. The system's so complex.
So these are ways that we could have persistent pain after tissue damage should be resolved, right? You mentioned these different things. So go back through those and let's dive into them a little bit more. I think one of the frustrations that I see my patients have, and even as a practitioner, is saying, well, where do we start?
Oh, yeah, totally.
Do you start with the evaluation of the tissue? Do you start with inflammation as a system? Are we looking just to decrease inflammation overall? I have a lot of patients who come in with chronic headaches, but they're more tension headaches. They're at the base of the head where it connects to the spine. And we're thinking, gosh, could that be musculoskeletal, or is it more hormones? Is it more? And I think some of that comes with good questioning, where we're saying, I tell patients, you have to be your own best detective, because I can only put a puzzle together with the pieces that you're giving me. So if you tell me that you are getting this pain wherever it is at the end of your menstrual cycle, that's helpful for me, because instantly I'm thinking there's a hormonal modulation of this, right? It's not just tissue injury if it changes with your menstrual cycle. So I guess I'm going off on a little bit of a tangent.
No, that's a really great question.
But I think it's really confusing of how do we start to unravel this ball of yarn of like, gosh, it could be so many different things. Maybe walk us through when you get someone, we'll stay with chronic pain because I think that's more of the issue that we're discussing. When you get someone who has a chronic pain issue, how do you even begin to know, have we fully evaluated the tissues enough? And then when do we say, like, this is just more of a systemic hormones, sleep, stress sort of thing, versus you're in that that chronic sensitivity, that nervous system sensitivity. So maybe walk us through how you would approach helping a patient.
So I've had a lot of mentorship through Carolyn Van Dyke, and I just want to, I can't talk about the stuff I've learned without crediting the people I've learned it from. And she has really helped me hone in on this. So as a PT, this is what I do.
Let me pause right there. Is that a typical PT, or you specialize in pain?
She does.
If someone goes to a physical therapist, is this the experience they can expect? Or they need to find a physical therapist that specializes in pain?
I would say you might have to shop around a little bit. Yeah, it depends on the setting. I treat one-to-one. So I have this privilege where I can do this. So I look for, whenever someone comes in, I assess tissues, of course, first. So I also do these questionnaires, and this is what I've learned, and they're validated through research to help me see what's going on with psychosocial factors that could be driving the ecosystem of pain. But first and foremost, as a therapist and a mechanical therapist, I am looking at the tissues, right? And I'm screening no matter what their pain, if they've been in pain 10 years or 2 days, I'm looking at mechanically what's going on with structure and sensitivity there. That's my first priority because that's what I do through movement and all of that. So I screen that first. And at the beginning, I'm having a conversation about the ecosystem. I'm not pulling this out after, and I've had to learn this, after I mechanically screen, and then I can't really find anything, and then I'm like, okay, let's talk about stress. I'm having this conversation at the get-go. I screen mechanically. I'm looking for joints, backs, hips. Do they like certain directions and certain loads? Do they hate certain directions and loads? Let's work with that to decrease the sensitivity of that joint, whether or not it's labral tear, whether or not it's whatever. Let's decrease the sensitivity of that through movement and load. If I really can't find anything, I look at, okay, let's have a conversation around and this is happening the whole time, what increases your sensitivity and your pain? Tell me more about the behavior. And then we talk about I'm listening to them. I will say that first. It's like what's going on with their system so I can better understand. And then we have a conversation around, okay, here's these questionnaires you filled out. And this is what I'm seeing. You're hitting the cutoff way beyond the cutoff of central sensitization, or your nervous system's hyper alert. What's going on? Does this feel real to you? And or stress, anxiety, depression. I'm screening for that so I can refer out if they might need a little more support. Insomnia, all of those scores. I'm not trying to overwhelm them, and I really keep it pretty simple, but I'm curious here because I am thinking maybe this is priming the pump for your pain system. Can you tell me more about that? Does this feel real to you?
Yeah.
Right? Because it doesn't matter if it's real to me. It's like, does this feel real to you? And then we get buy-in. It's like, okay, I can see the connection of why my migraines flare when my mother-in-law comes over. Like there's just weird stuff the body does.
Yeah.
And so it gives them more power over it. And then that's what I do. I think that is what you're asking. I start there with the tissues. I'm having a conversation at the beginning about the system. I'm listening to them. I'm wanting to know, where do they want to start? So I let them choose. And I do not give them 10 exercises.
Yeah.
After the first session, I'm giving them 1, max of 2 things.
Yeah.
And we just chip away at that sucker. If it's if this is chronic, persistent pain, it's going to take a while. Okay?
Yeah.
It's not, some people some are faster, right? We don't really know. But I think if people feel heard and they understand what's going on, they're buying and they'll make choices and decisions that are best for them. And I want them to lead that.
I'm often asked exactly what items I use and recommend, so I have a little gift for you. I have gathered my go-tos in one spot on our Amazon storefront. If you need deeper sleep, you'll find the light-blocking sleep mask that lives on my nightstand and that I use every night. If you're working on your bone density or your posture, check out the weighted vest I recommend for walks and workouts. We've also added the magnesium body lotion I reach for to calm the nervous system, my favorite laundry soap and cleaning products, and even the cast iron skillet that's currently sitting on my stovetop. All of these and more are organized by categories so you can browse trusted products without the overwhelm of trying to figure out what's the best thing to buy. You can head to amazon.com/shop/uplift for her, or tap the link in the show notes or from our website to explore the items I personally use and love. I hope this makes your life just a little bit easier. Now back to the show. Yeah, you touch on so many important things that I wanted to emphasize. I think number one, this is why the insurance system sometimes doesn't work very well, because the insurance system drives on time efficiency. And this is not efficient work. This is not a 10-minute visit, a 15-minute visit, even a 20 or a one-time 30-minute visit. Because you as a practitioner have this is how I visualize it as a practitioner myself, is in my brain, when you're talking, I have like bubbles or thoughts that are coming up and I'm thinking, could it be one of these 10 things? And as you're talking, I'm crossing off, nope, maybe. Yeah. And that takes time. It takes effort for you as a practitioner to let your brain kind of sift through the information, to gather the data, to sit and pause and think and let it set in and say, that's interesting. That's a little different than what I would expect. And then you ask more follow-up questions. This work cannot be done in 15 minutes.
No way.
It can't be done right. If you have an acute injury and you go to your doctor and you say like, I fell off a curb and now when I do this, my ankle hurts. Like, great, get an x-ray and move on with your life, right?
Yeah.
But these chronic pain issues, they take time. And our medical system, sadly, is not very well built for time. There are some areas that it's getting better. There's a field called physical medicine and rehabilitation, or PM&R. You say PM and R, but it's an and, not an N. And they do a really good job at taking time and slowing down and kind of pulling these pieces together. But I just wanted to emphasize that first off, of what you're describing, your brain is doing as a practitioner, and taking the time to listen and to validate and say, do you know what? I believe you. Yeah. I just don't know what the answer is yet, but I fully believe that this is your experience. And it does take some searching to find a practitioner who's going to use that model. So if you're frustrated by the medical system and you feel like no one's listening, that's a thing, and find someone who will listen. The other thing that I think you said was everything you said was so important, but in screening for anxiety and depression, I just want to take it back then, because I think so many women especially are gaslit to say like, I went to the doctor because I was having this symptom and they sent me home with an anxiety medication. And that's not what you're saying. I think when we say we're screening for depression and anxiety, it's because if your brain is in, I call it brain inflammation, depression and anxiety, if it's in a state where it's not firing the right ways, where you're chronically down or you're chronically anxious, that's going to change your experience with the pain. And if we ignore that, we're not going to get the results that we want with your pain. Right. So when we're screening for anxiety and depression, it's not so much so we can say, check, I found my answer, I dismiss you, right? Like, go get your antidepressant and don't come back because we found the reason for your pain. It's your depression, right?
Right.
That's not at all what you or I are going to do for patients. Right. But treating depression and addressing the fact that you are in a depressed state or a chronically anxious state is part of the healing journey to help that perception. Anything you want to add on that?
I come at it like it's helpful for me to screen for it, so I know maybe at what level. There's different cutoffs for like maybe getting some clinical help.
Yeah.
But I know that anxiety and low mood have been correlated with a sensitized nervous system.
Yeah.
So it's nervous system dysregulation. There's a physiological effect on the body. And so I instead of just seeing it on the list of the comorbidities they have, okay, we need to breathe, let's just calm down the stress, right? Yeah. I'm thinking, okay, this is priming the pump of your pain system. There's multiple movement strategies. I'm all about movement for anxiety and also depression. Yeah. So if someone's clinically depressed or say moderately depressed, research has shown cardiovascular exercise 5 days a week at a zone 2, like 60% of their max heart rate, can have huge effects on depression. So I'm always promoting like, okay, how can we use movement to help this, right? Yeah. And so I think that was an answer to your question. Yes, I'm not like, oh, this is the cause of your symptoms. I'm like, this is priming the pump probably in the ecosystem of the pain, what do you think about that? And see if that makes sense to them.
And also acknowledging that chronic pain can cause depression and anxiety because not feeling good is hard. Yeah. It wears on you physically and emotionally.
Chicken or the egg, right?
Yeah, exactly.
Yeah.
I want to go back a little bit because I think it's super interesting physiology and really helpful for people to understand this idea of sensitivity. So tell us about that physiology that happens where you say actually there's some people that actually you just touch gently and it is their body tells them that was really painful. Mm-hmm. And in conventional medicine, often we say like, man, you just chill out. Like you are just overreacting. But there's actually physiology that goes along with that hypersensitivity. Will you explain that?
Yeah. So I use that sign. It's called hyperalgesia or allodynia, right? Like non-threatening touch becomes threatening.
Yes.
And so I screen for that. I ask questions into that just to get a gauge of like, okay, I think we're dealing with more of a central pain mechanistic kind of system here. And as far as the physiology behind it, I can't remember all of the stuff because it's so freaking complex. But I will just say when the brain and spinal cord become so good at picking up pain, things that are supposed to be non-painful become painful.
Yeah.
And so your system's just so wired and so it becomes so good at trying to protect yourself. And so that non-threatening touch can become painful. And that's why pelvic pain, there's a huge amount of, I don't know what the right word is. There's a lot of nociplastic pain in pelvic pain.
Yes.
Right? Trauma in there. And I don't do internal work. My PTA does, but I can screen for it and I know, okay, the tissues are probably very sensitive just through hearing them talk about it. Right. Touch is very sensitive. So there's multiple ways we can go about to decrease tissue sensitivity. In a physical exam, I can do like more sharp, dull, like those kind of tests to see what's more sensitive and work with that. And they call it like peripheral sensitization, where the periphery, the tissues are sensitive. And then there's more the central pain mechanism. So there's a little bit of both. I'm still learning in that department because it's so complex, but I just see when non-threatening touch becomes threatening, there's a nociplastic component.
Yep.
How can we work with this? And there's different strategies there. Did that answer?
Yeah, it did. Yeah, I think it's so interesting. We see this sometimes after C-sections where someone will get we call it trigger point pain or trigger points, where you get this really acute pain that doesn't make any sense. It's way stronger pain than it should be. We see a lot of it in pelvic pain and in vaginal pain during sex, where it's like, this is out of proportion. And I call it mom voice pain. So I call the nerves, you have if you're a mom, when your kids are like, hey mom, 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 mom. And the more they bug you, then the higher reaction I'm going to give, right? The more they do it, the more I'm like, what?
Yeah.
And that's kind of what happens with nerves. If you sit and bug a nerve over and over, for example, if you get a tiny nerve stuck in your C-section scar, we can't see it, right? So we can't avoid them.
Yeah.
If you get a nerve kind of trapped in scar tissue there, then it's like every time you move a little bit, it's rubbing on that nerve. And it's like that kid going, mom, 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 mom. And eventually the brain is like, what? And then the brain will overreact every single time we get that movement after that.
Yeah.
And so that's that peripheral sensitization. So that central sensitization is more of that overreaction of the nervous system. You mentioned threat, right?
Yeah.
So our body, it's looking for threats nonstop to keep us safe, right? That's not malfunction, that's appropriate function. But if we've had experiences that rev that cycle up, then pain will be perceived more intensely for us because our brain is on high alert. So it's going to be like, oh my gosh, what was that? Oh, what was that? What was that?
Yeah.
And you might be doing something silly or totally ridiculous, but the brain is like, ouch. Oh, okay, just kidding. Like that didn't hurt, right?
Can we talk about that for a second?
Do. Yeah.
So I screened for this as well, but it's sounding a lot like worst case scenario thinking or pain. We call it pain catastrophization, which I hate that term, but it's this experience with pain that is totally normal in the short term.
Yes.
I messed up my knee a few weeks ago on the trail, and I go into about 72 hours of thinking I will never run again.
Right.
And I'm a PT, and I'm like limping. It's an acute inflammatory phase, and I am bummed. And my husband's like, "Can you just pull out of it?" And then that settles. And I start to move better, and I'm no longer thinking worst case scenario.
Yeah.
When someone has high worst case scenario thinking, that can actually prime the pump in our pain, and that's a risk factor for being in pain 1 year out.
Yeah.
1 year out, moderate to severe disability. And I think that's a part of that. It's like hypervigilance, right? And rumination around a pain. It's almost like this is pain, my hand is pain, and it's fused to the front of your face.
Yes. You can't see anything else.
You can't see anything else, and that is what's dominating everything. And that makes that pain system on high alert, keeps it going. And so how can we, educating people about pain is helpful to defuse, but also mindfulness and noticing and getting practice with mindfulness practices to detach from that, see it for what it is. But we also don't have to attach all the meaning behind it, right? Of like, I am never going to get better. This is going to spiral. What we believe becomes true, or like what's repeated in our head becomes true to us versus just the truth, right?
Like you said earlier, the brain doesn't know the difference between a thought and a real happening. If you are perceiving life as super dangerous, then your brain's like, got it. Hypervigilance. I will be on the lookout for anything.
Yep.
I think it's so important for people to understand in this situation. This doesn't mean you're making it up. It doesn't mean that you're a hypochondriac. It doesn't mean that it's not real pain. This is legitimate pain. It is legitimately your brain telling you that hurts. You couldn't intentionally ignore that if you wanted to.
Right.
But what we don't do is treat it with ice or treat it with, pain medications because it's not the same pain pathway.
Yeah.
It's actually your brain upregulated and saying, gosh, think about this, especially in situations of abuse, heaven forbid, or trauma where people get in a car accident and then they get chronic pain afterwards. We have to understand what else the body is doing. And you're saying ecosystem, right? What else is the body doing to store this memory of pain so that I can avoid it in the future?
Yeah.
Well, that's great and all, but you're not helping me anymore. If we don't recognize that's a thing, then we can't treat it. We can't address it.
Right.
But if we recognize that the brain actually has a role in this, then we have to address the brain. We can't just keep doing MRIs and steroid injections. I mean, those are great, and we should do them when we need to do them. But if someone's having chronic pain, we want to use more tools.
Right.
And part of those are understanding, like you said, do you have depression going on that's changing the way your brain is perceiving stress?
Yeah.
Yes. Do you have anxiety that's keeping you on red alert and having more threat sensations, right? Like, ooh, that one felt dangerous to me, even though it was just a little tap.
Yeah. I've never said this is in your head.
Right.
The brain is always a part of it.
Yeah.
But
I mean,
it's
it is in your head, but
it
it's
isn't.
in your brain.
Yeah.
It's like real. Yeah.
Or it's like not compartmentalized to me. It's all one.
And this is where it does get really powerful. And if you skip all of this explanation that we've just had and you just say, if a patient comes in chronic pain and you're like, have you tried meditating? It's not going to hit the same, right? Like you're like, dude, I just told you that I can't get out of bed because my back locks up, or I can't function anymore because of my neck pain. And you're like, I really think meditating on it would help. Like you're missing a whole bunch of the points in between. But if we understand like how pain actually works and understand how the brain plays a role in this, then suddenly it's like, oh, so maybe I should spend some time in stillness, connecting with my body and saying like, you're sending me messages. I see you, body. Yeah. I see what you're telling me. I'm just going to sit with that. I'm not going to panic about that. Like I can live with that pain a little bit. Mm-hmm.
Could we go into real quick some movement options for people with?
Yeah, I wanted to say, so like what can we do then? So perfect.
I'm all in I want to get people moving and living their best, healthiest, active lives. And even people with central pain mechanisms. I mean, a lot of us are walking around with that, right? It's not just this special population. It's just like all of us pretty much. But there's movement options for everyone. So let's just say I have someone who has a lot of stress in their life, a lot of stress, emotional load. Research has shown that there's effectiveness of yoga. I prescribe Tai Chi and Qigong for patients because it's new and novel for the brain. So usually central pain mechanisms like novelty. We need newness. We need to rewire. Neuropathic pain, it needs unloading, time for nerves. And then nociceptive, that's the joint. They like movement. We just got to be a little tricky there. So with the central pain, movement for stress would be yoga, Tai Chi, Qigong, anything that helps to evoke the relaxation response, but it also gets all the joints moving and all the neural pathways moving. So it's a great practice for people with high stress. You know, if they have a lot of pain catastrophizing or just like worst case scenario, hypervigilance, I go into mindfulness, also learning more about pain. This is interesting too. They've linked low self-efficacy. So if we get a client who just really feels like they have no power in anything, they can't do anything about their pain, probably because they've been seeing so many people. Research has shown they do not need passive treatments. The thing that actually can help is them feeling successful in their body. And so that's when I step away and I'm like, this is more about you than me. I'm not going to just massage or dry needle the whole time. Let's give you some success. And so stepping away from passive treatments have been shown through research. Also, if there's depression, anxiety, or even then that's priming the pump. Like, let's talk about what are some movement. Like, can we go for walks? Can we get that heart rate up a little bit, get it activated, and then some breath work after? So there's so many options for people. I know that's very broad. It depends on the resistance training. It's been shown to be very effective or help with depression, anxiety too. So I'm all in that category as well. So there's options. But at the same time, it doesn't have to be overwhelming. We can focus on one thing. I'm not saying you need to do all of this. Let's just focus on one, make that change, and over time, we can maybe add something else. You know, it does not need to be, you need to bat 1,000 from the get-go to get that pain down. And I think when we get in that tug of war of pain, like, I'm going to make this go away, it gets worse.
Yes. It's so interesting listening to you because what you do is it's a different field than what I'm in, although there is some crossover with chronic pelvic pain and different things. And I am often the first stop, you know, when people say like, well, I have this joint pain, I'll say, well, go see a physical therapist. I don't know joints. Like I don't know mechanics. I can't help you there. But hearing how you approach it is actually so similar to how we have to approach our patients with things like chronic fatigue or chronic inflammation or various things like this, where we have to start so slowly. We have to pull way back and say, stop running, stop doing Orange Theory, stop, exerting all the time, like pull way back. But we don't stay there. And I think that's where people make a mistake in physical pain as well as fatigue and healing, is that they pull back and they say, I guess this is where I have to live because I had to come all the way back and do nothing in order to function from a pain or from a fatigue perspective. And I say, no,
Yeah.
you have to pull back enough to touch bottom, and then you move forward again slowly. Yeah. So for chronic fatigue, we often do things like 2 minutes of walking, and then the next day is 3 minutes of walking, and then the next day is 4 minutes. Oh, 4 was too much. Okay, so 3 minutes for 3 days, and then 4 again. It's a matter of recognizing your limitations, but programming the body. One last thing I'll say about that, the way that I've explained it to patients when we're just talking about, the body is all interconnected, but so much of the way the body functions is based on programming. Yeah. So it's very much like a machine, like a computer. And you push all the buttons and you put in all the data and you put in all the programming, and then the computer goes ding and out pops the outcome, right? And if we want a different outcome, it's tempting to be like, the machine's broken. It's broken. I can't fix it. Someone figure out where it's broken so you can repair it. Yes. And that is that self-efficacy that you're talking about. We have incredible, I think, untapped powers to heal our bodies. Yeah. But we have to understand that before we can do that. And we have to understand that so much of the reasoning for why the body functions the way that it is the programming that's going into it. So in order to change the outcome, we have to change the programming. Yeah. And we have to do that slowly. You can't come in with a sledgehammer and break it up. You have to come in and tweak each knob and each dial and say, okay, how is my sleep? I'm going to try to go to bed 10 minutes earlier. How is my movement? You know what? I think I'm going to try that 2-minute walk. Mm-hmm. How is my brain? Maybe I'll just try to sit and take a 10-second breath. It doesn't have to be major. We just have to start consistently telling the machine, our bodies, what we expect of it. I expect to be able to move pain-free. Yeah. We have to keep telling our bodies that. Mm-hmm. Or I expect to be able to move with minimal pain. Yeah. And putting these pieces together to program the body to get what we want. It's so cool. It's so cool to go through that process with someone and see that it works. Mm-hmm. But it's slow and it can be difficult and it's tedious and requires a lot out of us as patients. But I think that it's so empowering to do that when you're not looking for the magic person who's going to heal you, the magic test, the magic imaging study, the magic pill that's going to be the thing that finally heals you. You are the thing that's going to heal you. With the team, a team that can help with medications and can help decrease inflammation and help tell you how to do this. Yeah. You don't have to do this on your own. But anyway, that was a really long-winded explanation, but it just strikes me that there's so much crossover between the way the body heals. It's the same if it's tissues versus cells versus hormones versus anything that we're dealing with.
Yes. As hard as physios or physical therapists sometimes, or it's hard for me, because people come to me with an expectation that I'm going to fix them. And you too, right? Yep. And sometimes I am magical because it's mechanical pain. Yep. And I'm like, I know how to do this. Yep. Right? And then it's like, okay, this is a pain system problem. And I have to have that language around, you know what, I'm not your fixer. Yeah. I am here for you. And we are going to facilitate this healing process. And let's just come up with where you want to start. So I think that's been humbling for me because I started out as I'm the fixer. And now I'm like, well, nope. Some within reason, right? Yeah. I can really help people, but it's less about me fixing. Yeah. And it's more of this team approach to helping people with persistent pain. Yeah. So.
Yeah. And it's one of the reasons conventional medicine is what it is in my conventional medical background, it's super satisfying as a doctor to have someone be like, I'm having heavy periods and it's ruining my life, and I take out their uterus and they think I'm a magician, right? Hey, period's gone. Mm-hmm. But to actually heal the body, to really allow it to be its fullest, healthiest self, it's not really part of the conventional model very much. Right. But man, it's so good. It's a good thing. And it's a good thing you're doing. So I'm glad you're doing it. We are out of time. Is there anything you want to wrap up or emphasize for women dealing with chronic pain that we haven't touched on?
I think we touched on a lot. Yeah. I would just say if you're in pain, sometimes it's good for people to take a vacation from trying to fix it. Yes. So if you need to take a break, that's okay. But seeking help that you feel like you are heard and that you can get on board with, and there's things you can do. Pain doesn't mean tissue damage. It's a huge experience, and we need to work on the ecosystem, where I'm not just giving you breathing just to breathe and calm down. It's like, no, actually we want to change the physiology happening. And so being open to other strategies is amazing. If people are open to trying new things, which a lot of people are, then I firmly believe people can get out of pain. It'll pop up here and there, right? And there'll be some flare-ups, but we can manage that if people know what's going on with their body and feel empowered to make some changes.
Yeah.
So, yeah, I think that's mainly what I want to leave with.
Well, thank you so much for sharing your expertise. I'm so grateful you're doing what you're doing. People deserve to have the care that you're offering. So tell us where they can find you. Sadly, it's just in the Salt Lake area that you're practicing right now, but tell us how they can find you.
Yeah, so I own Mindful Movement Physical Therapy, and I have another PTA I work with. We do spine and pelvic health. We do in-person and also virtual coaching. So I do have clients and coaching clients in other states that I work with.
Oh, awesome.
So just helping people understand their bodies better and get moving more and to feel good for the long haul. So that's what I love to do. And yeah, I'm in Holiday, just down the street.
Yeah.
Yeah. So
Awesome.
Thank you so much for what you do. I think it's huge, and more people need more comprehensive care, right? One-to-one care that spends time listening to people in pain, because it's hard.
Yeah. But doable.
Doable.
Yeah. Well, thanks so much, Emily.
Thank you for having me.
Thank you so much for tuning in to today's episode. A huge thank you to our guest for sharing their insights and time with us. We are grateful for the incredible support from our sponsors and to all of you listening. We couldn't do this without you. If you enjoyed this episode, please consider subscribing on your favorite platform. You can find us on our website, upliftforher.com, YouTube, Apple Podcasts, Spotify, or wherever you love to listen. And if you found value here today, please share this episode with someone who would benefit from it. Leave us a comment or give us a review. It really helps us reach more listeners like you. Thank you for being part of our community. Stay tuned for our next episode. Lastly, this information is for educational purposes only and not intended to be medical advice.